Okay, so everybody, we should be starting with the meninges, and hopefully you're pretty familiar with my drawings. And if we had to label some of these things, what would this part be called here? Cortex, yeah, cortical region. That's going to be your cortex in general. Just labeling a few things. This thing back here behind the brainstem, what's that thing?
Cerebellum.
That's cerebellum. Okay, then we have the brainstem, so you have your midbrain, your pons, and your medulla, and then underneath you have your spinal cord. Right, so everybody has a pretty good feel for where we are right now. This is like a looking at me straight view. Okay, so going from here, if you, I don't know if anyone knows this or not, but coming off the bottom of the spinal cord, you have these nerves kind of at the bottom. Does anybody know what those nerves coming off the bottom of the spinal cord are? These are called the cauda equina. Okay, cauda equina, literal horse's tail, right? Cauda equina. C-A-U-D-A E-Q-U-I-N-A. Let's see if I can get a little closer. Okay, so that's nothing more than something called the horse's tail. And does anyone know where you have your cervical vertebra and your thoracic vertebra, your lumbar and your sacral. But how about the spinal cord proper? Does anyone know where the spinal cord proper ends? What vertebral level it ends at? Did you know that it's a little bit? It doesn't go all the way down through the sacral levels. Okay, the very end of the spinal cord proper actually ends at L2. That's lumbar vertebra 2. I know you guys haven't had your anatomy quite yet. That's the L2 level. Okay. So what has to happen then is as the spinal cord travels down, since it doesn't reach the very bottom, the bottom part here gets kind of compressed. Okay, and I'll just represent this as the compression. All those L2 through the sacral levels get compressed in the end. And that's called, that compression has a special name. That's called your conus medullaris. Okay, the conus medullaris is nothing more than the compression of all those spinal cord levels into the very end so that it fits through L2. Yeah, does that make sense? Everybody get a feel for that? So it ends, the spinal cord proper is going to end at vertebral level L2. Okay, when we think about meninges, does anybody know how many meninges there are? Meninges are going to be just like a covering over the central nervous system. There's actually going to be 3 distinct layers of meninges that we're going to talk about today. The first layer is going to be tightly adhered to the CNS. Okay, so it's tightly adhered to the surface of the brain and the cerebellum, brainstem and the spinal cord. So just using a green color here. So all the way down, around, back up. So this is nothing more than the first meningeal layer, and this first meningeal layer is tightly adhered to the CNS. Okay, and it covers it directly. Okay, this is going to be the first meningeal layer that we're going to talk about. And the first meningeal layer is known as pia matter. P-I-A. M-A-T-E-R. So, pia matter. Is that what I think so? Yeah, so pia matter. Does anyone know what the word matter means? Okay, the word matter means mother. Okay, and the word pia means soft. So pia matter, which is tightly adhered to the CNS, is going to be the soft mother. Okay, that makes sense. You have a nice soft lining covering all of your brain and spinal cord. Moving on to a color. Let's go ahead and choose orange for the next layer. Okay, so the next layer, the next meningeal layer that's directly over the pia mater, and like I said, the pia mater is tightly adhered to the CNS. There's a little bit of space here. So the next layer has some space. I'm going to represent that here. Okay, comes in. And there's going to be some space between this meningeal layer and the pia mater. Just like that. Just going to like a little indent here. Okay. This second layer is known as arachnoid matter. A-R-A-C-H-N-O-I-D matter. Okay, so we already talked about that matter means mother. What do you think arachnoid might mean? Yeah, spider mother. Okay, so your second meningeal layer, just over top of the pia mater, is your spider mother, or arachnoid matter. And that arachnoid matter is named the spider mother because it has projections coming off of it down toward the pia mater that help maintain that physical space. Okay, I'll draw these projections here. Okay, and these projections have a special name, and the name of these projections are trabeculae. I'll write that up here. Trabeculae. So the projections coming off the arachnoid matter to help maintain the physical space between the arachnoid and the pia mater are known as trabeculae. Does anyone know what that physical space is that the trabeculae help to maintain?
Subarachnoid.
That's correct. That's the subarachnoid space. Great. Okay, so in here, we're going to label this space, which exists everywhere around, and it's called your subarachnoid space. Well, that's pretty easy to remember because it's directly below the arachnoid matter. Okay, your subarachnoid space. You see, is there something hard to see, Jonathan? Or
I was just looking at that screen.
okay, that's fine. I don't know if it's coming through as clear as it. Yeah, that looks fairly clear. Okay, so first layer, pia mater, soft mother. Second layer, arachnoid matter, spider mother. And then we have the third layer. The third layer I'm going to choose to do in, I'll do a darker blue, or just a blue in general. Let's do, yeah. Okay, this third layer, and there's really no, there's a potential space, but not an actual physical space yet between this layer and the arachnoid matter. Okay. Just draw this here. Okay, again, goes all the way around. It's the final layer, and this layer is actually composed of two different parts. We're going to take a bird's eye view of the two different parts here in a minute, but for now, I just want you to know that there's this third layer, and the name of the third layer is the dura mater. D-U-R-A. Okay. D-U-R-A-M-A-T-E-R. So we know matter is mother. Anybody know what the word dura means?
Durable.
Tough. It's one tough mother. Okay? And this is a harder outer coating for the CNS. So in general, there's going to be 3 different layers. Pia mater, closely adherent to the CNS. Arachnoid mater. Arachnoid matter has a little bit of space maintained by trabeculae. And the third layer is called your dura mater, and that's like a harder protective shell. Okay. Does anyone know what's inside the subarachnoid space? It's filled with cerebral spinal fluid, or CSF. We're going to talk about that here in a minute. Just kind of giving some hints. Now, we talked previously about the fact that there's this separation or indent here between the left and right hemispheres. Does anybody remember the name of that fissure?
Longitudinal.
Correct. This is going to be the longitudinal fissure. Put it down here. Okay. And it turns out that that dura mater, or all the meninges, kind of invaginate into that longitudinal fissure. And when that happens, that space or that area is known as the fa cerebri. So this right here, this invagination, it's kind of like a harder shell. If you can imagine the dura mater, anybody have crab before? You know that crab. There's like the membrane that it's almost like a plastic kind of membrane. That's equivalent to the dura mater. It's a harder outer covering. Yeah, Jonathan?
So it's like the inlet part that needs to be dissolved.
Mm-hmm. Yeah, right in here. So it kind of comes down into the longitudinal fissure. And again, we'll look at it more closely in a minute, but I'm just kind of giving, and this is known as the F-A-L-X cerebri. Okay, and it's nothing more than an invagination of the dura mater into that longitudinal fissure. Protection. Okay. And then there's also another fissure that we haven't talked about yet. We talked about the lateral fissure, and that lateral fissure was around that temporal lobe, that thumb of the boxing glove, that lateral fissure there. But there's another fissure, it's going to be right here, that's the invagination or the separation of the cortex from the cerebellum. Okay, does everybody see that invagination right there? That has a special name. That's called your transverse fissure. T-R-A-N-S-V-E-R-S-E. That's your transverse fissure. Transverse fissure is nothing more than that separation between the cortical region and the cerebellum. Okay. Well, it turns out that the dura mater also invaginates into this fissure. I make a little extension here. And then this invagination also has a special name. Bless you. That invagination of the dura mater into the transverse fissure is going to be your tentorium cerebelli. Tentorium, T-E-N-T-O-R-I-U-M, cerebelli. Okay, and again, that's going to be the dura mater invaginating into that transverse fissure. actually makes it difficult to pull out the brain because when you try and pull out the cortical region, that tentorium cerebellum won't let you pull out the cerebellar region. So you actually have to remove that to get it up. Probably more than you need to know. Okay, questions about this? Does that make sense? So this is just a great big 360 overview of the meninges. And then there's one more thing I need to tell you. I can't see the bottom. I told you that the spinal cord proper ends at L2 vertebral level. Okay, but with the meninges surrounding, the dura mater actually extends to S2 vertebral level. Okay, so 3 different layers of meninges: pia mater, arachnoid mater, dura mater. Overall, a couple of invaginations that go into the main fissures. Fossa cerebri into the longitudinal fissure, and tentorium cerebellum goes into that transverse fissure. Okay, beneath the arachnoid mater, there's something called the subarachnoid space. That physical space is maintained by the presence of trabeculae coming off the arachnoid mater. Got it? All right, let's move on. Next, we're going to look at cranial meninges. Okay, let me tell you. So what I'm going to do right now is I'm going to zoom in to this portion of this first diagram. So I'm just going to be looking specifically in this area. So all I've done is I've blown up this area. And we're going to take a real close-up view of what exists right here. Okay? To see that, I have the cranial meninges. Okay, we're going to specifically look at all the meninges that are part of the cranial region. Is there a question? Or no? Question? No? Okay. All right. Labeling this, what I've done is I'm looking at just a frontal section straight down. Okay, so if you took a knife and just went straight down on me, this would be a frontal section. And this area right here represents the skull. Okay. And then this area down here just represents the cortical region of the brain. So you're going to have, if this was a frontal section, this would be the right brain cortex, and this would be the left brain cortex hemisphere. Okay, everybody see where we are? That's nothing more than, we talked about the fact that on the outer surface of the cortical region, you have all that gray matter, nothing more than lower motor neuron cell bodies, and that's what this represents here. It's a little bit gray in color. So let's go ahead and start labeling some things and zooming in a little bit closer. And there are actually, as the skull grows, it grows and fuses together. Does anyone know what the lines of the fused skull? Yeah, those are your sutures. Good. Okay, these represent the sutures of the skull. Okay. Sutures of the skull actually are really important, and because they're going to be very tightly adherent to one of the pieces of dura mater that we're going to talk about. I mentioned that the dura mater actually has 2 different layers, so we're going to see the 2 different layers here, and the first layer of dura mater is very tightly adherent to the skull. I'm going to represent this in a dark blue color. Okay, it's particularly adherent to these sutures. it's really stuck to the sutures. Okay, this is nothing more than the first layer of dura mater, and that first layer of dura mater is known as your periosteal dura. Okay, that's your periosteal dura layer. And as I said, that periosteal dura is really tightly adherent to the sutures. And just under the periosteal layer, we have another layer of dura. And this dural layer is known as your meningeal dura. Okay? Meningeal dura has a little, think of it as a triangle. That's where the invagination of that dura mater that forms the false cerebri comes in, right there. Okay, so this is going to be your meningeal dura layer. Meningeal dura. Okay. Meningeal dura layer directly underneath the periosteal dura layer. And then you see that there's this little invagination of the meningeal dura here, between the meningeal dura and the periosteal dura, right where the area of the longitudinal fissure is. That little area is a special structure, and it's lined with endothelial cells, so I'll represent those here as red. That's known as your superior sagittal sinus. I'll write that up in a minute. Okay, superior sagittal sinus is going to be the main vessel that drains all the venous blood from CNS circulation, as well as that CSF fluid, and we'll look at that as the class progresses. I'll label that as this little invagination here. This area is known as your superior sagittal sinus. Everybody with me so far? Yes. Alex.
Same part of red dots are the
They're just endothelial cells, yeah. Cells that line blood vessels, essentially. That's just representing that space. Jonathan? Yeah. Yeah, that space, this whole space is what is the superior sagittal sinus. And that's going to be a place, which you'll see in a minute, where all the venous blood drains into to help remove it from brain circulation, as well as the CSF drains into the superior sagittal sinus too. Any other questions on that one? Okay, moving on down. So, 2 layers. Now we know dura has 2 layers. Periosteal dura, tightly adherent to the inside surface of the skull, particularly to those suture lines. Okay. Then there's right under that is meningeal dura. Meningeal dura has this invagination that actually goes into the longitudinal fissure. What is that? What is this thing? I labeled it a bit ago. Does anybody remember what I called this plastic part coming into the longitudinal fissure? It's called your falx cerebri. F-A-L-X. Cerebri. Okay. Right under your dura mater. Does anybody remember the next layer of matter? Spider? Arachnoid matter. Okay. Arachnoid matter is going to be right under your dura mater. Here. Okay. And the arachnoid matter had those trabeculae sticking out of it to help maintain that physical space known as the subarachnoid space between the arachnoid matter and pia mater. Okay. Label these here. These are going to be your trabeculae. Okay. And then make it clear, this space here created by the trabeculae, that's your subarachnoid space. So nothing new really, not yet. And then we have tightly adherent to the cortex, or to all the CNS, you have your pia mater, or soft mother. I'll represent that here in green. There's a layer directly in contact with all the sulci and gyri, the cortical region. Yes?
So the pia and the arachnoid go around these separate lines, like the false cerebri.
So the false cerebri is nothing more than this physical space. Yeah. So you're saying that it's contiguous. Yeah. So the arachnoid matter comes around it's part of the meninges in general. Those are all for protection. Okay. Okay. And the pia mater itself is tightly adherent to the brain. Any other questions?
Is it green
Yes.
pea matter? Just
The green is pia mater. Yeah, I just chose green. Pia. Okay. Yeah, the green is just the pia mater. I can label that. So same as the last slide. So that's your pia. Okay, and I guess I didn't label the orange here. This is your arachnoid matter. So kind of the big difference between this picture and the big overview picture that we looked at a minute ago is that I've added 2 layers of dura, the periosteal dura and the meningeal dura. Okay. Yes.
So do the trabeculae attach to the pia mater, or
No.
they don't?
No, they don't attach yet. They're just there to maintain that space. Is that your question? Same thing? Okay. Yes. So the pia mater and the arachnoid matter are really fine. They're not like a tough membrane. They're kind of membrane, but not like the dura matter is more like an elastic, a hard shell, harder shell. And then the pia mater and arachnoid matter. That's a thin membrane, a fine membrane. And then this Yep. Okay. So, good question. So, inside the subarachnoid space, there's going to be a fluid. I talked about it just a little bit, and we're going to talk about it a whole lot more as we go through the ventricle system. Inside the subarachnoid space here is going to be cerebrospinal fluid. So how do I? So I'm going to say the subarachnoid space is filled with, it's called CSF. CSF is cerebral spinal fluid. Like I said, we'll talk a little bit more about CSF when we get to the ventricular system, but you should be very aware that the subarachnoid space is filled with CSF. CSF is cerebrospinal fluid. Okay. In addition to that, the subarachnoid space also contains what we were talking about the other day, is the blood vessels. Sort of mentioned it a little bit now that I have more information. So all your cerebral arteries and all your cerebral veins are actually floating in CSF in the subarachnoid space. So this guy, here's a cerebral artery. Pick your favorite. I like the MCA personally. You get a patient with right MCA CVA, you have no idea what to expect. So that's probably why. And this is a cerebral vein. Okay, your cerebral arteries and cerebral veins are floating around in that CSF. That is in the subarachnoid space. Okay, we're going to talk about the importance of that. And I also mentioned just briefly that the cerebral veins actually drain into this superior sagittal sinus. So I'm going to represent that here as like a little bridge. And I like to think about it as a bridge because that little vein has a special name. It's called a bridging vein. So this right here is going to be a bridging vein. And that bridging vein is nothing more than vascular structure that attaches the cerebral vein to that superior sagittal sinus. And you can see the way that superior sagittal sinus is running straight down the middle of the head. So you can envision those bridging veins as going into the superior sagittal sinus like this. Okay, if my fingers are the bridging veins, they're going in like this. And that's going to be really important when we talk about something in a minute. Okay, does everybody get the concept? So you've got your bridging veins. Yes, Jonathan.
Can you just repeat what it's bridging like?
Yeah, it's a bridge between the cerebral vein and the superior sagittal sinus.
And it's draining.
It's draining the venous blood into the superior sagittal sinus from the brain circulation. Is that your question? Okay. Okay. Any other questions? Great questions. Ben, yes?
So would that superior sagittal sinus be right on the mid-sagittal line?
Right. Correct. It's in that longitudinal fissure. It's just sitting right there. So here's the longitudinal fissure that's between the left and right cortical regions right here. That superior sagittal sinus runs all along, front and back, along that longitudinal fissure. And those bridging veins are set up like this to connect to that sinus. Other questions? Can you picture what I'm saying? Does it make sense? See it? Overall, is there other questions? Feel free to ask me. I just want to make sure it's clear. Okay. If there are no other questions, then let's move on. So this is the cranial meninges. Now, I want to draw these in detail. And I like to put them on the same page so I can compare and contrast, and you'll have kind of a better feel for what these things are. These are something that I guarantee you will see patients with these two things this summer in the clinic. Okay? We lost it. Where did it go? Okay. So what I'm going to talk about are epidural versus a subdural hematoma and the important differences between them. And to do that, since I put them on the same page, I'm going to choose to draw a dotted line to separate the two. Okay. And on the left side of the page, this is going to be the epidural hematoma. And then on the right side of the page is going to be your subdural hematoma. Has anyone heard of these before? No? Never heard of a subdural, epidural hematoma? You will. You'll see patients with them. I'm just going to talk about exactly what they are and some clinical signs and symptoms that are common and a little bit of treatment can cause. Okay? So let's go ahead and start labeling. Like I said, I'm going to start over here on the left side of the page with the epidural hematoma. And the epidural, again, this is a skull. Okay. And that skull has the suture lines that we labeled a minute ago. And I'll put sutures. Okay. And all I'm going to do from here is I'm going to put in my layers of meninge, and I'm going to choose to represent the epidural hematoma on the far left side. And you'll see what I mean here in a minute. So the first layer of dura that's tightly adhered to the skull, specifically the sutures, what was that called? That's your periosteal dura. Okay. So periosteal dura is going to be here, tightly adhered to the skull and the sutures. Okay. Then when we get over to this side, that's where I'm going to represent my hematoma, and the hematoma is an epidural. That means it's above the dural. So what happens is that periosteal dura tightly adhered to the sutures, but when there's no suture, you're going to get a big old pool of blood here between the sutures. And that's characteristic. Suture line to suture line filled with blood is going to be characteristic of your epidural hematoma. And here's the hematoma. Does everybody see that? Yes.
Is hematoma a condition or disease?
Oh, the hematoma is just a pooling of blood. Yes, the hematoma is going to be your pooling of blood. And we'll talk about what's going to happen. I'm just trying to show the details. So we have our, let's label that. There's my blue. This is going to be your periosteal dura. Okay. And I can even label this as, here's your hematoma, which is just the pooling of blood. Okay. And then right under your periosteal dura, what was that next layer? Meningeal dura, great. Now remember that meningeal dura has that invagination that forms the superior sagittal sinus. Okay, so you're going to get something that looks like this. Okay, where the right side looks pretty normal, but the left side is kind of being compressed due to that epidural hematoma. And the next layer under the dura, yep, this is your arachnoid. That's your arachnoid matter. So here's your falls cerebri. Then underneath that, you have your arachnoid matter. And again, arachnoid matter's here. Just like that. And that arachnoid matter still has the trabeculae coming out of it to help maintain that physical space. Only in the area of the hematoma, it's really compressed. It's compressing on the brain. Okay, let's label there's the meningeal dura. Okay, this is arachnoid. And then the pia mater, which is tightly adherent to the CNS, or like I said, the sulci and the gyri of the cortical region, I'm going to represent normal over here on this right side, right? Kind of looks like what we just saw there. But over here on the left, it's going to be severely compressed, so it doesn't, you're going to have some problems, right? So you're getting, because of the presence of that epidural hematoma, all that blood is pooling up under the skull with nowhere to go. It's going to press on the brain, okay, and cause some problems. That make sense to everybody? Okay, so again, this is the green is the pia matter. Let's talk about causes. Okay. Cause for an epidural hematoma is going to be some sort of trauma. Right? A hit to the head. It can be have an associated skull fracture or not. Okay? But whatever that trauma or that hit to the head is, the epidural hematoma is formed because of the rupture of meningeal arteries. This periosteal dura layer is highly vascular. And so the trauma causes a rupture of meningeal arteries. And so it's the hit on the head causes the rupture of the arteries, and in that specific area the blood starts to pool between the sutures of the skull. And that pooling of blood causes compression of the brain. And some symptoms, so signs and symptoms of an epidural hematoma. It's very specific. Yes. Valerie? Yeah. You can try. Well, you'll have to. So what'll happen is you'll have to tell me to move it as we go. There. Is that better?
Yeah, that's a lot.
A lot better? Okay. So yeah. So signs and symptoms. One of the biggest sign or symptom of the epidural is going to be something called a lucid interval. LUCID. A lucid interval. Okay, so I'll give you an example of a lucid interval, and it might be something similar to what you hear this summer if you have a patient with epidural hematoma, is that, let's say Grandpa's walking down the steps and he falls, it's in the middle of the night, he hits his head, and family's all concerned, and Grandpa gets up, family gets him up, and he seems to be fine, no problems, his head hurts a little bit, it's kind of sore there, but he's okay. And then 2 or 3 days later, he's non-responsive. You can't wake him up. He's in a coma. Okay? The lucid interval is the time between the bump on the head and when he went into a coma. So in other words, he's normal post-trauma, but then non-responsive. So I'll say normal right after trauma, eventually turns to non-responsive. Over time. And that the amount of time that it takes for that lucid interval to turn into coma is going to be dependent on the size of the bleed, or how much blood is actually pooling there. Does that make sense to everybody? So you get that hit, the meningeal arteries are teeny tiny and they start to pull blood, and then all of a sudden you're non-responsive because you have a lot of compression going in over here because of the blood. Yes? How much blood, is actually accumulating, and how quickly it accumulates, really. How quickly it accumulates. Okay. Yes.
So, any sort of geriatric patient had a fall, would you just want to make sure that wasn't occurring? So, since they have that lucid interval, how would you know that the one that isn't actually in an okay situation, or
Yeah. The way to detect the pooling of blood in the skull, in the brain area, in the area of the brain with epidural hematoma would be best by CT. Yeah. So that if you thought there was going to be a big enough bump, you might want to take somebody to get CT. Any other questions? So the last thing I want to talk about is treatment. So the treatment, and again, you'll probably see somebody that had an epidural treatment, an epidural hematoma this summer. What you see as a PT is well, what they do is they actually take a drill, and they drill right into the area, right through the skull, and release the blood from that space. Okay, and that drilling, what they're called is burr holes, B-U-R-R-H-O-L-E-S. And burr holes, usually there are 2 or 3 depending on the size of the bleed. But what you see in the patient is that they just drill straight through, and then they just take the skin and a few sutures, just a few stitches right there to cover it up. But that's it. It's not super big deal for treatment for an epidural hematoma. Yes.
How small the holes? It's like little pinpricks?
Like that. No.
Oh.
About the size of a pea. Yeah, they go in and drill.
And that doesn't go back.
Go ahead, Dr. Blair.
You know, I love nerdy history stuff.
Yeah.
There's evidence in like prehistoric man of burr hole surgeries, what we call trepanation, probably maybe in those prehistoric times to relieve pressure from a subdural or epidural.
Yeah.
Torture.
Yeah.
And people survive it too.
Yes, Ashley.
So although all the layers are being compressed in the cell space, what's important is that part of the brain is
Yes, the more important stuff. I understand your question. I think that, so let me try and answer and see if it's the right answer. So is it more important that the subarachnoid space is compressed or the brain is compressed? The answer is the brain is being compressed. Okay? Yes.
How does this affect the patient post-treatment? As a PT, what would your next steps be after the treatment?
Okay. Same as my treatment would be for any patient that I come in contact with, and that is to identify their deficits. What are they having problems doing? Is it walking? Is it strength? Is it balance? Or all of the above? So I do a complete evaluation of the patient, figure out, and also collaborate with the patient, figure out what they want to do, and then work from there. So through the same treatment as anything.
Let's say it happens, the trauma happens, and then you wait 2 days, but then you go to the hospital before the coma starts. Is there still risk of brain injury that could affect at that point, or?
I haven't, from an epidural hematoma, my personal experience, I haven't seen anyone with a severe brain injury. The subdural hematoma I have, but the epidural, because it's so confined to that one area, is a little bit different. That person might know what hematoma, but once they clear it out, it's usually okay. And the subdural hematoma is a little bit more severe than that, as was the subarachnoid hemorrhage. We'll talk about that. Any other questions? Yes, Alex.
After treatment, do the meninges correct themselves and go back up to the skull?
I don't know the answer to that question. I would assume so. I would assume there's some flexibility in the system because of the CSF floating up. Do you know, Dr. Blair? The question was, after they drill out the hematoma from the area, do the meninges go back up? I assume they do, but I don't know for sure. Have you ever heard anything about that?
That's a good point. I don't know if they reattach them or not. I mean, I know they just cover it with like a membrane to prevent meningitis infections of that, but I don't know if the meninges ever reattach to the.
Yeah. So that for the burr hole treatment, I mean, I'm just seeing a couple of sutures, but I don't know what happens inside. I don't know. I mean, I would assume it does, but I don't know for sure. Okay. Any other questions? One more question, Julia.
Does the amount of time that it doesn't take place between accepting something that's severe
The faster the bleed, the shorter the illicit interval. Okay. So if the bleed's really small but doesn't stop, then it's going to be a longer period of time. Yeah. So that's something to be aware of. So if somebody comes in and they're not responsive, you want to ask family members if they get head. So sometimes, I mean, some PTs work in the ER. It's an interesting job too. Okay, let's go ahead and take a 10-minute break.